Hello, my name is Jeff Galloway. I am a first-year medical student at Rocky Vista University. I've been fighting a cold since Friday, so I apologize if I sound very congested. So, let's talk about our patient, Ray, who is a 45-year-old African-American male. His chief complaints are periodic dyspnea and fatigue. He also complains of occasional dizziness with no syncope, proximal generalized muscle weakness, and no orthopnea. The patient has a history of depression, but we don't know whether he has been diagnosed with depression, whether he receives any medication for this depression, or if he's been receiving any other treatments. So we're already finding some pretty big information deficits here. The physical exam is showing conjunctival and nail bed pallor, diffuse abdominal tenderness, and no evidence of trauma. The patient's vitals include a normal temperature, but a slightly elevated respiratory rate and a slightly elevated heart rate. Some of the information deficits that I found important in this case are what capacity was the patient working at this mine? In other words, what was his job? Was he in the field or was he in an office? If he worked there for 10 years, was he staying in the same area, and were the conditions of the mine the same? What kind of toxins was he potentially exposed to while working there? Again, with his depression, is this diagnosed? Is it being treated at all? Specifically, is he taking any medication for it? Does anyone else in his family have aplastic anemia? And going beyond that, what is his family medical history? Especially with congenital type disorders. What is his normal lifestyle like? What does he find important? What would be significant from his point of view for losing or having to deal with as far as treatment or illness goes? So for differential diagnoses, the most likely that I found was aplastic anemia. This has to do a lot with the fact that it can be caused by, amongst other things, an exposure to toxic chemicals, and it also results in cardiopulmonary problems like the ones that he's presenting with, and gives pallor and fatigue. So I felt like it fit the bill more than any other. Some of the other differential diagnoses here: orthostatic hypotension, and this one popped out at me because it can result from any medication for depression can result in this. And this one has the particular symptom, the absence of the orthopnea, while having many of the other symptoms that were present with the patient. There's also acute as well as chronic myeloid leukemia. Acute can form from exposure to industrial chemicals. Again, we don't know what role he was working at the mine in. It also results in abdominal fullness and fatigue. And, chronic myeloid leukemia is many of the same reasons as acute myeloid leukemia, although this one's a little bit less well understood as far as the causes. And then I also added in a zebra with pheochromocytoma, which can result in tachycardia, fatigue, and pallor. And I liked adding this one on just to have something that is fitting the symptoms but outside of the box of where we're thinking with the rest of this. So for aplastic anemia, this is by the Mayo Clinic defines it as a condition in which we're having the stem cells have been destroyed or are just otherwise absent. And So we're having a result of pancytopenia, which is a reduction in red blood cells, white blood cells, and platelets. And we're also having this hypocellular bone marrow, but specifically without splenomegaly, which we didn't see as a complaint with his. We're also seeing the potential for recurrent infections, bleeding episodes due to the lack of platelets, and fatigue. And there's also a risk of many other complications, and it's long-term approach type therapy, so not a one quick fix. It can be caused by many things, including toxic chemicals, and gold is mentioned specifically. Again, we don't know what minerals were in the mine, but it can also be genetic in nature, so family stuff is coming back too. The disease mechanisms are not well understood at this time, but it's been proposed so far that it could be linked to lymphocytes actually causing it. So a toxin or virus is activating these lymphocytes, and then these are inhibiting hematopoiesis, specifically through interferon gamma. So some of the labs and studies we can use, the most important is the bone marrow biopsy for getting the diagnosis, as well as understanding the severity level of it. And I have listed here the different kinds. So if it's less than 30% for cellularity, we just call that moderate. But if we're getting less than 25%, we're calling this severe, as well as some other conditions that are listed that could also make it severe. And then there's also another kind called very severe aplastic anemia. And so we're getting severe, and then we're also getting the absolute neutrophil count of less than 200 microliters per liter. Then there's also a complete blood count. It is also used as a lab for understanding whether or not we're having the pancytopenia, which is reduction of those three cells, red blood cells, white blood cells, and platelets. So the treatment and management, the go-to is bone marrow transplant to replace the stem cells for aplastic anemia. And this one, for individuals over the age of 40, but below the age of 60, the 5-year survival rate is around 50%, so only half. So it's a very severe, life-threatening condition, clearly. The treatment's by no means foolproof, but definitely capable, definitely a viable option. You can also receive regular blood transfusions. We may also be using, in addition to those, immunosuppressants, specifically cyclosporins, antithymocyte globulins, corticosteroids, colony stimulating factors, or antibiotics, antivirals. And because of the use of immunosuppressants in this, as well as the hematopoiesis that's occurring, he needs to avoid any activities that could result in injuries, specifically cuts or falls. He's got a low platelet count and bad immune system, so manage that. Some of the ethical considerations, as I just said, is he may need to stop doing some of the things that he really likes to do if he's put on these immunosuppressants, and if he does in fact have aplastic anemia. So, we don't know what he likes to do for fun. Does he play softball or any other sports or something regularly? So this is definitely something to consider. And then with regard to the possibility of orthostatic hypotension, he may need to cut back on depression medication if he's actually on any. And we don't know what level his depression's at, because it's just described as being episodic in nature. So is this also going to make it worse? Is he currently really needing that to get through things right now? What's the nature of that? We also need to discuss what his belief system or religious beliefs are, and it would be important to involve his family, friends, and community with regards to his treatment. For the education of the patient needs to be aware of the risk factors from depression medication, as well as the injury with regards to his condition. We need to, as with any patient, we need to inform them of disease treatment, the progression, as well as the potential impact on lifestyle. And I use the phrase inform, but the whole process, it needs to be a process, and it needs to be shared decision making. So we need to make sure that the patient is included in the whole treatment process, that they're not simply being subjected to our medical advice. It needs to be maintained as advice. I've listed here the references used, and the patient's condition here is very serious but manageable. So thank you for your time and consideration.